Welcome, everybody. We are at New Jersey EMS Fellowship Journal Club. So it is February 13th, 2019. We are in North Arlington, which is in New Jersey. So I'm supposed to tell everybody to like us on Facebook. I believe that's a technical term. And so everybody knows we are going live right now. We are, let me see, we just got back from, where did we just get back from? Austin, right? And at National Association of EMS Physician meeting, we had the top 3 articles, of the top 30 articles of the year in GEMS, we had 3 of the top 10, and then we had the NAMSP abstract of the year. So congratulations, Matt Harris. I know you're texting me that you're probably watching right now at Denver Children's. We also are I'm going to the Eagles meeting in Dallas to talk about our pre-hospital transesophageal echo, and with my buddy Zap from Penn, we're going to talk about pre-hospital Reboa, which we have on our physician vehicle as well. So resuscitative endovascular balloon occlusion of the aorta. We're going to get started here, and if you have any questions, please type them in, and we'll do our best to answer them. I should say that we are taking our journal club on the road, so if you have some place in, well, let's say New York, New Jersey, or how about Eastern Pennsylvania, we will potentially come to you and set up our shop in your home. We've gotten a few requests, so that's great, and just let us know, okay? Also, I just want to say real quick that for everybody who wants to log on, I've been telling you about the fellowship website, which you hopefully should know by now, is www.emsfellowship.com. We started in January our 501c3, our nonprofit, which is www.md1, that's number 1 program.org. That's www.md1program.org. And we function solely on we do not bill patients, we should say that. For our physician response, which will take place anywhere in the state of New Jersey, we're pretty much successful not billing anybody, so we function purely on donations. So every little dollar helps. Please just log on to the website and donate even $10. Every little bit helps for these catheters. Just the Reboa catheter here is $3,000, and if we put it in tonight, that is no bill to the patient, as opposed to a $10,000 bill. So let us know, type in your questions, and we'll try our best to answer them. All right, we'll start with interesting cases. Interesting cases, anybody?
So I have an interesting case. So I was working in the emergency department, but it was our own paramedics who presented it to me. So I have a little bit of both perspectives. So this was a gentleman in his 50s who had attempted suicide by taking pills. He left a note at home. He had also been released from the hospital a few weeks before after an inpatient psychiatric hospitalization when he had slit his wrist. So all very intentional. And when this crew presented the patient to me, they presented it as a patient who was altered and confused with a weird cardiac arrhythmia. I found out later from the family that they had left the house and found the patient at home lying near the bathroom with some blood around his mouth, and he was confused. Whenever you asked him a question, the only thing he could say was a date, and that was his birthday. No matter what you asked him, it was the same every single time. And he was also very, very shaky, and he was flushed. So he came into the emergency department. The first thing that I noticed when I saw him was the EKG that the crew handed me, and it was a bigeminy rhythm, in kind of like an accelerated junctional rhythm with no visible P waves, but every other beat looked like a PVC. And he had discussed whether, I guess the first question was, should something have been given? I believe he had called in for orders and was told, because he was right near the hospital, just to proceed in. The patient wasn't hypotensive, he was normal tensive, but with this abnormal rhythm, and he was altered. So.
Abnormal rhythm, altered drug overdose.
Yes.
So what's the diagnosis, anybody? Or what's the differential?
Right.
TCA overdose?
All right, TCA. We see less TCAs, tricyclics, than we used to, right? Because everybody used to be on, it was a primary drug for everybody. Elavil or some other TCA was a primary drug for everybody who was depressed. Now we put them on Lexapro or 10 other drugs, right, for depression. But we still do TCAs for a variety of things, including like nerve pain, a variety of different things. So, sure. So TCAs go into what category?
Of Oh, like sodium channel?
Like what category of drugs are they in? That can
Antidepressants?
right, but what bigger category? So what properties do TCAs have that can cause an altered mental status?
Sure.
What'd you say?
I don't think it's. I didn't say anything.
So like what other category? What category do TCAs fall in that can cause altered mental status? So if I'm asking you what causes altered mental status with drug overdose, so somebody's overdosing on drugs. Let's go back one step. If somebody's overdosing on a drug and they're seizing right here in front of you, what's the drug?
It could be a bunch of different
It could be a
things.
bunch of things. So what's most common? Drug-induced seizures. Cocaine.
Cocaine.
Right? Cocaine. So drug-induced
So
seizures.
sympathomimetic.
Sympathomimetic. Right? So it's cocaine. And it used to be that if you were in the inner city, it was cocaine. If you were in the suburbs, it was tricyclic antidepressants when we used to give TCAs to everybody. But I'm thinking of anticholinergics, right? So anticholinergic can cause drug overdoses plus altered mental status. So what are the other drugs that are anticholinergics that can cause altered mental status and possibly seizures? Right? Because every time I do something to a patient, somebody's seizing, I give a benzo, right? The benzo doesn't work. I give a benzo again. It still doesn't work. And the seizure hasn't stopped. Right? Every time I do something twice in medicine, if it doesn't work, I start to say, what am I doing wrong? Right? So when somebody seizes, what are you going to do? A, nothing. B, give a benzo.
You're beating me to the punchline.
A, nothing.
By the way.
Right,
In my
nothing.
case.
Who cares? They're seizing. It's no big deal. People seize all the time. It's not some big deal, right? They seize at home. People have 100 seizures at home every day. The most important thing you can do is what's a seizure. You don't have to rush to give any silly drug,
Protect
right?
the airway.
That will make them more hyperventilate more, right? Watch it. How many people are out there who have who are on medicines, like everybody used to be on Dilantin, now they're on Keppra, for seizures, when actually nobody's ever seen the seizure. They just come in and we hear about the seizure in the emergency department, so we give them a drug, right? So you watch the seizure. It's okay. We were the ones who proved that febrile seizures can be transported by BLS. They don't need ALS at all. That's when we proved it, but multiple people have shown this in the literature, right? Because what do you do with a febrile seizure in a kid? You have them go back to sleep, right? That's what we do. We check them on the ER. If they look okay, we don't get silly blood work. We don't get silly x-rays. We don't get silly urines. We basically just say to the parent, go back home. And they're very, very, very unlikely to seize again during the same medical illness. In fact, if they do, they're no longer simple febrile seizure, right? So it's almost unheard of. So anticholinergics. You want to take it from here? Is this what you're going to talk about?
Yeah.
All right, go ahead.
So I found out that the medication that the patient was taking, we had a few actually. So we had Celexa, which is citalopram, which is an SSRI, so selective serotonin reuptake inhibitor, putting more serotonin into his system than normal. And the second medication he had taken was Seroquel, which we know is a very dangerous atypical antipsychotic that can cause QTC prolongation. So it turned out that he did have a prolonged QTC on his EKG, and when he had gotten to me, he had gotten, I think, a fluid bolus, and his bigeminy had resolved, and now he was a sinus tachycardia. But what was interesting is after a small amount of time in the emergency department, he started to get more confused and lethargic. He started to fall asleep, and when his mental status deviated, his cardiac arrhythmia returned. So he was back in this bigeminy rhythm, and he kept saying his birthday over and over again, which I found out from his family was the date that he was saying, because he kept saying the same date over and over again. And I just didn't like the way things were going in terms of his mental status, so I made the decision to intubate him. Okay. So
did you have an idea what he took before you intubated?
I did find out that it was those two medications, okay. And I believe there was a third medication that I think was nothing significant. So I went to go intubate him, and when I was preparing the intubation, he did start to seize at that point in front of me. So he bit his tongue. There was a significant amount of blood in his airway, and I gave him 6 milligrams of Ativan over the course of 5 minutes, and nothing was breaking the seizure. Luckily, I had another attending who was with me, and we got poison control on the phone. So she was on the phone. I was managing his airway. and we gave him ketamine for the intubation to start it off with. I wasn't sure initially if I wanted to do more of an awake intubation or an RSI, given everything that was going on with his arrhythmia. And he was also a challenging airway. He had a small jaw, was very anterior. So what I've become in the practice of doing is whenever I anticipate a bad airway in these community hospitals where I know I'm kind of by myself, I always mark the neck with a Sharpie. So that's something I was taught in residency, just as a very, very last resort. It's kind of
So you
something I
mark
know.
the neck for the cricothyroid membrane in case you have to do like a surgical airway.
Just in case. It's like a good luck charm. If it's there, I don't have to use it. That's how I feel. So, we gave him the ketamine, and actually right after we did, he stopped seizing, which was fantastic.
Of course, ketamine fixes everything. Ketamine's a better drug for seizures than benzos.
Yeah.
And in 10 years, we'll all be giving ketamine as opposed to, Versed, Valium, or Ativan for seizures. That's my guess. Who knows if that's true? But, a patient you can't check his vitals on who's in status, a great choice.
Exactly. So,
And we do this pre-hospitally, right? We give ketamine for refractory seizures pre-hospitally.
absolutely. So, I think if I would have had this patient in the field, I wouldn't have done much else differently.
Right.
And I was able to, when I went to go take a look, I put the suction catheter in first because I wanted to make sure I could clear out all that blood. And luckily, I had a really good respiratory therapist who was able to jaw thrust him and get his tongue out of the way because he was biting physically on his tongue. So I was able to secure the tube. I did choose to use a video. I used glide scope. Just kind of went in very slowly because he was so anterior, and I don't endorse one device over another, but in my experience I've done well in the past personally with anterior airways with the glide, so that went just fine. And we also gave him rocuronium right after I got my view. So I didn't, because it's glide, I didn't put the
Right. So that was
camera all
good.
the
So
way
you
in.
got your view, and then you gave him rock. All right.
Yeah, like kind of right all at the same time. And that was fine. And poison control recommended using propofol for sedation after that, which went well. No issues, no hypotension, nothing like that. And then they wanted me to perform
They made that up, right?
Yeah.
They made that up. There's nothing special about propofol with those overdoses after intubation, right? Is there? No.
I don't know why they chose that. I think
They just
Probably
this is
what
like
they were
because you can
familiar
turn
with.
it on and off. It's what you're familiar
Sure.
with.
It could
All right.
be to get
Maybe
a
it's quick on and
neuro
quick
exam.
off. All right.
That
So-
way you can get a neuro exam if you need to.
Yeah, I was,
Ooh.
you're right there. So, the next thing they asked me to do was actually do a gastric lavage. So I've only been asked to do this like once before in my experience with a Tylenol overdose, but usually you use a very large tube to do this, put a large amount of
An E-wall.
saline, an Ewald tube, exactly. So I asked the site that I was at where I could get one, and the charge nurse laughed at me, and then she called the house supervisor, who also laughed. Apparently Dr. Tanis also asked.
Because we don't do that anymore, right? Pumping
Yeah.
people's stomachs out, something we haven't done in 20 years in medicine.
It used to
People
be,
still talk about
yeah,
it. But
It used to be very popular.
20
It's essentially like a garden hose with a blunted end, so that you don't break anything.
So when did the patient do this ingestion?
It was unknown. They think it was within 4 hours. The last time they saw him normal, a family member had gone home and found him.
No. I wouldn't have done this personally. I wouldn't have done it. 3 papers: Kulig paper, Marigan paper, and something else paper. I forget the third one. All say that if somebody takes the pills within 1 hour, then maybe there's some evidence of gastric lavage helps, but maybe. And this is why in medicine we've kind of stopped doing it.
Right.
Because these were like chromium studies, right? And when they tag the pills with chromium, you push the pills further down into the duodenum when you lavage somebody's stomach. That's why we stopped doing it in medicine, because even though you think you're doing a good thing by getting pills out, you're pushing more pills into the duodenum.
Right. And they mentioned that to me, and what they actually had me do is give 25 grams of activated charcoal down
Yeah, I knew you were gonna
the
say that.
OG. And that's exactly what they said. They said if anything goes past the pylorus, you should catch something. But again, not something really common that I'd done before, except for one other time. So I thought that was kind of interesting.
I don't know. I think show me a paper. 25 grams. We normally give like 1 gram per kilo, although that's kind of a made-up thing too we do in medicine. Why 25 grams, like as opposed to 26 grams? It's,
Yeah.
I don't know, it sounds a little...
I think his total dose with his weight, because it should be 1 gram per kilo, was he was like about 75 kilos, so it was 75. So they actually wanted 25 on the front, lavage till clear, and then 50 on the back. So I mean, I didn't. Still,
You only have to give
one.
one dose of activated charcoal for everything in medicine except what drug?
Oh,
You only have to give one dose of charcoal for every drug in medicine except for one drug. Theophylline.
right.
Theophylline
The
is
multi-dose.
multi-dose. There's a few papers here and there about other drugs, but which are long stories. But theophylline's been studied more than anything else, and that's probably the one drug.
Yeah, the only other thing that I did right away, and I'm not sure.
And nobody's on theophylline anymore for the most part.
That's
right?
true. You don't really see it anymore. The only other thing that I did when I first saw the patient and I saw his arrhythmia going in and out is I gave him 2 grams of mag, because just in case he went into torsades, I thought I'd throw that
Right.
at him.
So let me just.
It was like 586.
I forgot if you mentioned, did you get back Carl?
Oh, sorry, not you said
that's what I was just
QRS. I meant to
gonna
say
ask.
Q. Sorry, let me correct myself. So QTC was 586.
Right, I knew you meant QTC.
And for the QRS actually was not prolonged, but in my head, when I first saw the patient, the first thing I actually gave him was bicarb as well, just in case.
Right, that's what I was going to ask, because bicarb is an antidote for cocaine overdose, right?
Exactly.
Most people don't know that. It's like a board question, but it's right. Why? Because cocaine, I think, is I always forget this. It's a 1B sodium channel blocker, maybe a 1C too. One of you who are closer to
Cocaine.
boards than me, tell me. Cocaine is like a 1B. It's a sodium channel blocker, so you override the sodium at the sodium channels and you give bicarb, and it's the antidote for cocaine overdoses and when cocaine is causing ventricular arrhythmias. Who knows if the guy took it or not? But it works. It's good for like any sodium channel blockade.
Right.
Right? I'm just giving cocaine as an example. Right?
So I guess the question is to bring it kind of all together is, if this is a patient that I'm taking care of in the field pre-hospitally, would you just kind of throw the mag, throw the bicarb and
Yeah.
at this guy? And I think probably
that's the downside.
if I
I would
saw
have given the
him
guy
in Gemini-
bicarb. I would have given him mag. I would have. Let me ask you a harder question. So let me. What in the old coma cocktail? What we used to do for everybody who was unconscious?
So glucose, naloxone.
Naloxone to everybody. We just throw this at everybody unconscious. And what was the third drug?
Paradoxine. Oh, that's for seizure unconsciousness.
No, but you're
Something with a P.
but you're somewhat close.
Anticholinergic overdose.
Yeah, you give it
Delirium.
antilirium.
Yes.
What's the other name for antilirium?
It's not phentolamine. It's
Physostigmine.
Yeah. Use
Right,
it.
antilirium.
It's a P, but it
it's one of
sounds
the
like an
cool
F.
names in medicine. Antilirium. So you give it to people who are confused, right? And it's a really cool drug because somebody overdoses on an anticholinergic, right? So let's say the classic overdose that we see is like Benadryl, right? So somebody goes and takes like 200 Benadryl, right? 300, 400 Benadryl, and what happens? They get anticholinergic side effects, right? So they get big pupils, dry mouth, slow bowels. They get their bowel slows down. They get urinary retention. They get hypertension. They get altered. They get arrhythmias, right? So that's all the anticholinergic side effects. And so then you give physostigmine. So they go from being like 240 over 140 with ventricular arrhythmias and hypertension with a wide QRS to all of a sudden a blood pressure of 110 over 70, like that. All of a sudden the mental status is totally awake. All of a sudden they look absolutely perfect.
And it's
Just
instantaneous.
it's instantaneous. It's one of the few things in medicine where you can wake somebody up like immediately.
Yeah. The problem is that there's such a big dogma behind it
Right.
that we don't use it enough. But
It's
if
just
you have
another
someone-
example in medicine where we've totally been wrong
Right.
and screwed up everybody.
Right.
We have this thing, physostigmine, because if you give physostigmine to a tricyclic, we used to think it causes asystole and it's done myocardium for years. So it got poo-pooed in medicine as a drug we shouldn't give, and once again, we were totally wrong with what we were doing. In fact, there's this guy at Penn State named Donovan, who's a toxicologist, who for years has everybody who's altered, well, not everybody, but most people, he's been giving physostigmine to. Probably it's the largest collection of physostigmine data in the world. And you know what happens when he gives physostigmine? Nothing. They get better or nothing. They get better or nothing bad happens, right? So you don't go into cardiac arrest when you get physostigmine. That's just a myth that I bet if you surveyed most ER doctors, they would still say not to give physostigmine. But
Everyone would.
yeah, but it's like a great drug. It's safe. So why don't we have it on paramedic units? Probably because we don't have that many anticholinergic overdoses to warrant it.
Right, there's less
But
TCAs out there.
It's probably a cheap drug, although it's good for any anticholinergic.
Great for these bad overdoses.
Huh?
gratefully Benadryl overdoses with his kids.
Yeah, we see
especially
Benadryl
when kids
overdoses
are
all the time.
Very altered. I mean, you give it and they reverse right away.
Right. But so what's the worst thing that happens when they take 1,000 Benadryl? Right? I mean, most of them are going to be okay, right?
Yeah.
They don't need anything special. They don't need gastric lavage.
Right. I mean, I had a patient who was like, we discussed this with some of my residents, and there was a patient who was altered, and she overdosed on like Tylenol, she overdosed on like NyQuil, and I had a discussion with the residents, and I said, what we did, because the patient was thrashing around, I just gave her Versed IV, I put her down, and then we resuscitated her and gave her an
Because most cold medicines are either sympathomimetics or anticholinergics, right? I always have these cold medicines which say does not cause drowsiness.
Right.
No kidding. It has no anticholinergic in it.
Right.
Thanks for the information. I mean, completely unregulated industry, these over-the-counter
Yeah.
medicines, right? Completely unregulated. Most of what's on the bottles is just, it's so silly what they write.
Yeah. So, I mean, my thought process was, I said, we sedated her, and then we resuscitated her, and then we put her on, started MAC on her, just because it was NyQuil and Tylenol overdose. But I was discussing with the resident, I said, this patient was altered when she came in thrashing around. What could we have done? And I said, we could have just tried physostigmine and see what would happen.
Right.
And actually, if it helped, and if it
Right.
really
That's
changed
brilliant.
her, it'd been
Did you
great.
do it?
No, we didn't, because I snowed her. So because she was thrashing around, we wanted to start because I knew it was polysubstance overdose.
Yeah.
There were like four drugs that were involved, and I knew that it was a Tylenol overdose. I wanted to start the NAC right away.
Yeah.
And so I wanted to sedate the patient appropriately and then start my therapy. But I said one thing we could have done, which we didn't do, and we had a discussion about this and the dogma behind physostigmine and why we don't use it and why people are so afraid of it. But toxicologists, all the brilliant toxicologists talk about this as being a drug that's great and it should be used, but it's so underutilized.
Do we carry it on the physician vehicle?
No.
We got to
We
change
should.
that. Can we get it tomorrow?
Sure.
Let's
Yeah.
get physostigmine. I mean, we got no downside. We're going to help a few people. We'll prevent some people from being intubated.
Yeah.
And we'll have people that we can make better, like in 1 second or less. And how cool is that?
Nobody else has it on the truck.
Right. Probably nobody in the country has a pre-hospital. And what's our? I mean, everything's a risk first benefit, but I can't think of any risk, right? Besides the old dogma that's just not true.
It's pretty cheap too. It's been out forever.
Right? Is it cheap?
Off-label,
Yeah. And antilirium sounds so cool.
It does.
And then, so what are the other? So what are the other anticholinergic drugs? By the way, the over-the-counter cold medicine. I mean, I'm sure I worry about anticholinergics and sympathomimetics a little bit, causing seizures.
Sure.
But I worry about DXM, right? Dextromethorphan,
Yes.
right? I mean, in other countries you can buy pure DXM. You can't buy that in the United States because it's mixed with other stuff. And but DXM causes what? What does dextromethorphan cause? What syndrome? When
You
you
start
take-
sweating, you get hot.
Yeah. Yeah, serotonin syndrome. So it's what all the kids get, right? They all take dextromethorphan. They all take Corseed and HC. That got a bad rap in the press, but that was kind of silly because lots of drugs have dextromethorphan. And you take like 30 milligrams, and you pills or liquid, and you take like a couple. You take like at least 10 of them. You get a couple hundred milligrams, and you get a serotonin syndrome.
We should add
But they get really high. You get high from dextromethorphan.
We should add the cyproheptadine to the drug box.
Cyproheptadine is the antidote for serotonin syndrome.
We should
Right.
add that as well. We find this thing.
My guess is that's incredibly
I'm sure that's
expensive.
going to be very expensive. Yeah.
I don't know.
Med, you have to go through an NG tube. The last time I gave it was in a PICU, but you have to crush it up and put it through an NG tube.
That was another thought that I had. Maybe I should have, when I was reviewing the case myself, I'm like, maybe I should have tried that as well.
You have to crush it.
Give her symptoms
Yeah,
because he
what
took
the
all those
heck?
SSRIs.
But yeah, what the heck? So
They gave him NAC as well,
they get
which was
max
interesting.
For Tylenol. Yeah, I mean,
They're like,
I guess
just in
what's the
case.
downside? Everything's Tylenol, right? And they all start off being asymptomatic, right?
Yeah.
Right. What's the old saying? How do you know the difference between an aspirin and a Tylenol overdose? The Tylenol overdose will have no symptoms, zero, and just took enough to shut down the liver and have no complaints. The aspirin overdose will be about to die,
Yeah.
right, and look really, really sick, and that's how you tell. And let's train everybody out at home for what a toxic overdose is of Tylenol, because whenever people say to me, "Can I take a third extra strength?" Right? And the answer is, go ahead, take a fourth extra strength. Right? It's 140 milligrams per kilogram. Take your weight divided by 2.2. That's your weight in kilograms. Multiply that by 140, and that's how many milligrams of Tylenol you can take to be toxic. Which probably means that most of you need to take 10,000 milligrams of Tylenol to have a toxic overdose. Right now, I'm not encouraging you to try this, I'm just saying, like, an extra Tylenol is not that big a deal. With that, people then, the next wish is, well, then how come the package insert says no more than 4 grams in a 24-hour period? And the answer is because we are incredibly conservative in the United States. How many people, how much we want people to take. And we're not talking about chronic overdoses. I'm talking about like a 1 dose and no more after that. Right? That's different than taking multiple doses like over and over.
I think they lowered it down to 3 grams now.
Oh, I heard that too.
Yeah.
Right? It's
So it used to be 4, now it's 3.
But do you know that if the average person takes 650 milligrams, so a therapeutic level of Tylenol in your body is 10 to 20 milligrams per deciliter. We don't check that, right? But when you give people like a 2 regular strength, they never get therapeutic. Right? So everybody says, I take Tylenol, it doesn't work, I take ibuprofen. That's because you took 800 ibuprofen and you compare that to 650 of Tylenol. Do you guys ever give 650 of Tylenol in the hospital? I see people do that.
I don't.
Only if they're the tiny, skinny people.
Okay.
And they're 15 mg per kg.
But a
equals
regular
that.
adult?
No,
regular
not usually.
Everybody gets
I usually give a gram or 2 grams.
Right. And then people call you and say, did you really mean 2
Some
grams?
people
You're like
usually
crazy.
do 2 grams, right? But I usually do 1 gram because I get less of a headache from people. But typically, I give sometimes even up to 2 grams.
Yeah.
And I'll usually pair it up with Motrin, ibuprofen.
Because you can
Yeah.
get both at the same time.
Sure.
You know, the American College of Pediatricians, they came up with that position statement not to tell parents to switch it back and forth between Motrin, Tylenol. That's because they thought the parents would mess it up,
Sure.
right? But in fact, it's totally okay to take both together, right?
Yeah.
In fact, I mean, what do we do for a fever if it's not bothering the patient?
Nothing.
I mean, the biggest issue with Tylenol, I think, the reason why I think they're limiting it so much is the concern or the dogma behind Tylenol being such a rampant cause of overdose and such a rampant cause of liver failure within the United States. If you go anywhere, we get Costco-sized Tylenol bottles in the U.S.
Yeah.
But if you go anywhere else in Europe,
blister
they have
packets.
blister packs.
Yeah.
Right? So if someone wants to go
Paracetamol.
and kill themselves, they go to their medicine cabinet, they get a bottle of Tylenol, and they kill themselves. But if you go to Europe, you're going to have to sit there and pop open
Too much
100
work.
blister packs
Right.
in order to overdose, right? And that's going to limit you.
But it's even worse than that because the toxic dose of Tylenol is different in Europe versus the United States, right?
Right.
There it's like it's 200, and here it's 140 or 150.
Right.
Right, so it's different. That's because our FDA has more stringent standards than they do in other countries.
Sure.
I mean, how long did it take us to get the antidote, NAC, approved in an oral form? Right, we had it. It took us years and years and years.
Right.
Right, it's just so silly. But how often do we get Tylenol overdoses? I mean, we get them, but it's not like every day,
I think
right?
it's one of the highest overdoses in the U.S. though. So
Okay, that's
Behind
fair.
opioid, of course.
So it's the higher incidence within the United States.
Because it's easily accessible.
Because people take what they get their
Bulk
hands
value.
on.
Yeah. So I think because of that, there's stricter regulation behind it, and I think that's probably what's driving this more than anything is that we just have such a high incidence.
Right.
The big thing is you just get that big jug of Tylenol
Yeah. It's just so easy to take and overdose.
or acetaminophen.
Versus ibuprofen, you can take 100 milligrams per kilogram and not overdose on that, So.
Well, we
ibuprofen
want
is
people
such
to do
high-
that,
Oh
right?
yeah, but
Because we know, right, because it's, the old adage, Tylenol is 15 milligrams per kilogram in kids, right, in babies, right?
Sure.
But that's lower than the recommendations on the bottle. And Motrin is 10 per kilo,
Right.
although, don't give it in the first 6 months of life,
Sure.
based upon bad studies, right? And have you guys been taught that you can't give Motrin in the first 6 months of life? Right. You ever ask anybody why?
No, actually.
Right, because there's not good literature to support that, but that's generally the mantra we have in medicine: don't give them the first 6 months of life. All right, that's good. Anything more about that case?
He actually did just fine. I just checked up on his records today, and his mental status is improving. The only thing is I think he had some renal complications, but I'm not sure if that was related to his ingestion or
Why would he have renal
potentially a
complications?
rhabdo.
Did he have some maybe rhabdo?
Could be. Not sure.
To the
Why would he have
point where
rhabdo? Was he lying on the ground for a long time?
It sounds like he wasn't, so I'm not really entirely sure.
Season?
Could be.
Oh, maybe because he was his
Even-
status. So maybe he was in rhabdo because of status.
He had an elevated white count also, which meant nothing, as we know,
Yeah.
of 25. So I gave him a lot of fluids.
Right. All right. So you got a lot of fluids. One of the last good reasons in medicine to give a lot of IV fluids to somebody, rhabdo.
Yeah,
All right.
sure.
What would you do a patient who's in rhabdo and having like a GI bleed?
Are they on blood thinners?
Let's say no. So they're in rhabdo and they're having a GI bleed. Do you give them a lot of fluid or not?
Well, I would give them off feeling because I wouldn't check for the rhabdo.
All right. And then when you all right. So all right, another interesting case.
Yeah, I got a couple we can talk about.
Here.
It's we were working in the emergency department. We had a stroke alert. 80-year-old guy. Like told talking to him, he's normal. His wife goes out to the store, comes back 2 o'clock that afternoon. He's confused and dropping things and slurring his speech. So he actually has a syncopal episode and seizure activity in front of the medics. Unable to intubate him in the field, they end up placing a king tube. So he comes into the emergency department, status post ketamine and paralytics, and has a king tube in place. All his numbers look okay. Unable to assess his stroke scale or anything like that, but we wanted to convert the king tube. That's all right. Wanted to convert the king tube to an endotracheal tube before we sent him to CAT scan. And I don't know if this is on or not.
Is it green light?
Yeah.
Perfect.
So we set everything up. We had time. His sats were good. He was being ventilated well through the king tube. I actually placed, while we were setting everything up to get his resuscitation on, I actually put him on the ventilator with the king tube in place.
Oh, that's
and
great.
The respiratory therapist went bananas. Can't do that. Oh my God. And I'm like, listen, just write my name down. It's all right. I said it's okay.
And of course, what'd you do with the vents?
So regular intubation settings. You know, he was a big guy. We had him on a tidal volume of 500, 100%. Respiratory 18. We peeped him at 5, and it went fine. So we set up for the intubation like a controlled setup where we had our supplies bedside. We ramped them appropriately. We used a guide.
You put 2 nasopharyngeal airways in.
Yep.
So get everybody at home. So it's 2 nasopharyngeal airways in. Always, always, always. Right?
So we got to that after we pulled the king tube out. So the king tube was in. We were ventilating him through the king tube. We placed gastric tube, OG tube, through the gastric port of there, decompressed his belly, had multiple IVs. We set up, we fixed his blood pressure, we gave him push those pressure, and completely optimized him before we went.
Did a lot come out of the gastric tube?
It was more air than anything else, but we decreased the size of his girth, abdominal girth, and so completely optimized everything as much as we could to intubate
What's his
this
blood
guy.
pressure?
His blood pressure initially was low. It was 90s. So we gave him more push dose. I gave him some 20 micrograms of epinephrine empirically because his shock index was bad. Was right on the borderline.
You were worried about paralyzing him.
Yeah.
So every medic should know this. What we're saying is going to change a patient's life. Who's 257? They're not here. So we're saying stuff that's going to change their life. So we don't want people to paralyze. If you're hypotensive, I want you to think twice about paralyzing.
Yeah.
I'm not saying it's not indicated.
Right.
Just think twice because you're about to make somebody more hypotensive.
Yeah. So we brought
So
his
you
pressure
thought
up.
about that, and
We
that's
thought about-
why.
absolutely.
And that's why you gave
We
them.
used ketamine and rock, and we gave him push dose pressors before with the induction medicine to bring his blood pressure up to avoid the peri-intubation hypotension.
Oh, that's great.
Because we had all the signs of it,
Because the worst thing for a stroke is to be hypotensive.
drop his pressure. Absolutely.
Yeah, nothing's worse than that.
We never dropped his pressure. Everything went well. We got to a point where everything was perfectly optimized as best we could. We made a decision. We had an airway plan set up where we were going. First attempt was going to be with the direct laryngoscopy with a MAC 4. We were going to intubate him with an 802. We had everything planned up. We had a bougie. We had suction. Everything to go. Took the king tube out. He got ketamine before. We gave him more ketamine. Lots of secretions in the mouth. So it was a little bit of a challenge.
Did you know that you were going to have secretions beforehand?
Yeah, absolutely.
So I'm just playing Monday morning quarterback. What about giving like a pyrolate or something?
We didn't pre-treat him with that. No, I didn't think of it at the time, but that's probably a great idea.
Or you could argue atropine, but
Yeah.
he may be tachycardic, and the glycopyrrolate won't cause that.
Yeah. But
All right, so
first, to intubate him, the first look, I missed. It was a misintubation for the first round, but it was such a controlled environment that we were able to reassess everything. We put two nasal airways in, an oral airway, good jaw thrust, went back to a bag valve mask. Had his sats back up. He never lost his blood pressure, never lost his heart rate. His sats were always good. We, bag valve mask ventilated him, changed the plan. He was already ramped. He was already optimized. He already had a high flow nasal cannula, everything on the nasal airways. I switched to the glide scope. Now, what I identified...
Why'd you
what-
bag him? Why don't you just put him on like back on CPAP or not?
He had no active respiratory effort. He was
Okay.
he was paralyzed. So, I switched to the glide scope, and I usually use the glide scope blade number 3. This guy's pharynx was so deep and anterior that I actually went to the glide scope 4, and I usually don't use the 4. And I needed every bit of that blade to get the.
Why'd you pick a glide scope as opposed to?
It's the only one we had available in the place I was working at. So our first attempt was direct laryngoscopy, and our second attempt was video, and I had no problem. We actually had trouble getting through the glottic opening because his cords, when we saw his cords were closed even despite paralytics. So we had to pass a bougie first, and then able.
Oh, that's good.
And then able to place a tube over the top of the bougie, and he
So
was
the
successfully
bougie.
So use the bougie with the glide.
Yeah.
Yeah.
And then so what happened when you hit the cords with the tip of the bougie?
Actually had to gently push it through, and then when we put the endotracheal tube over it, we were held up at the glottic opening, and we had to rotate the endotracheal tube to take advantage of the bevel on the end of it to get around the cords and the retinoid cartilage and everything to get in. And after that, it
Was there any way to predict this will be a difficult airway?
his body habitus, absolutely. He had a king tube in. He had lots of secretions in his mouth, sure. So we did everything we could with the exception of the glycopyrrolate, but everything we could to optimize the intubation.
Yeah.
It took me 2 attempts, but we had no adverse complications from it.
Right. So he never got bradycardic, hypertensive,
No, we
or
had-
hypoxic, right?
we took
It's
care of
not
all
getting the
that
tube
stuff.
through the cords. It's not getting the tube through the
It's the
cords.
path to
it's
get
the
there.
journey,
Yeah.
right? If you get the tube through the cords in the first attempt, but you get bradycardic, hypertensive, and hypoxic, maybe you haven't done a good thing. I don't know. Maybe the patient's sick and dying, and it's the best you could have done.
Yeah.
But you just have to think, maybe I didn't do a good job. Right?
Yeah.
It takes you 5 attempts, but they don't get bradycardic, hypoxic, or hypertensive.
Correct.
That's maybe okay.
So we required more push dose pressors to keep his blood pressure up. We got the tube in, we got him off the CAT scan, and just a catastrophic bleed. I think I sent you the text.
Oh yeah, you showed me the bleed.
Yeah.
His entire brain was blood.
Yeah.
He's gonna have a bad outcome. Oh, did he die?
Yeah, I think so.
He probably herniated.
Yeah, he was already
He probably herniated
herniating.
pretty quickly.
Yeah, I mean, he was bleeding all the way down into his brainstem. The neurosurgeon said it was the worst one he's ever. The radiologist said it was the worst scan he's ever seen.
So what history of hypertension?
Hypertension only, no blood thinners, no AFib, no
Untreated
NACs.
hypertension?
He was his blood pressure was fine when he came in. He was on PO antihypertensives. It was just a sudden spontaneous bleed in his brain, non-traumatic, that was just catastrophic. So he ended up on peripheral Levophed. and
So
up to
this
the
is a
ICU.
guy really ended up peripheral levophed.
His heart rate and blood pressure dropped.
Wow, that's terrible. I assume we always forget to sit people up, right? Sit them up, sit them up. When you intubate, sit them up. Nobody should be lying down for any reason in life, right? None of our 911 patients. Sit them up, sit them up, sit them up. When you intubate them, sit them up before you intubate, sit them up while you're intubating, and sit them up after you intubate. Do not do any of this stuff while somebody is lying flat. And especially when they have anything in their brain, keep them sitting up, right? As much as you can, at least 20 degrees, right? As much as you can. And certainly after we intubate somebody's on the vent, do not let them lie flat, right? But sit them up every single time, right? Do we see enough people being intubated sitting up? No, and it's a shame, right? Because
ramped up pretty high.
this is a study. This is a AJM study where we looked at it. People had better, easier intubations when the more they were sitting up. Not just the xiphoid process to the intubator, but even higher than that. Do you guys do all your intubations sitting up a little bit?
Yes, I haven't lied a patient completely.
How often do you walk past somebody's bedside and they're intubated like on a vent and they're lying flat?
All the time.
all the time? And you know what? I think it's almost
Why haven't we fixed people? Well, why are people still doing their own thing?
Well, it's interesting because, as the attending or as a supervisor, you have one of us at the head of the bed, and it's someone always is first instinct when you say, okay, I'm ready to intubate now. Someone out of nowhere just grabs the handle of the bed and brings it down. And I'm like, no, I don't want that. I want it up.
So I
Almost
have a
no
quick
matter
question.
what.
Is there any reason to have somebody lying flat anymore in medicine? How about pre-hospitally? Do we have somebody lying flat anymore? I guess you have them lying flat if they are a trauma patient with a neurodeficit.
I agree. Or an unstable C-spine.
All right. So how about?
I mean, even
besides
that, they don't necessarily need to be flat. I like to elevate the head a little bit. It takes the pannus off the chest.
It depends what they are.
lines
But
up the
in
airway.
general, the advice we would give to pre-hospital providers is if they have a neurologic deficit or if they're altered after a trauma, we should lie them flat. No longboard, but we should have them lying flat. And anybody else who's a trauma, who has neurologic deficit, you can send them up at least 20 degrees, right?
Neutral.
But besides that patient, is there anybody else we should lie flat in 2019? Can you think of anybody?
Can't think of anyone.
Yeah, I can't think of anybody else either. All right, so that was good. So yeah, he had a terrible bleed. And then it's even terrible that he got hypotensive. But did he get hypotensive because of the paralytic?
No, I think it was actually his brainstem was under pressure because he was bleeding all the way into his brainstem and herniated, and I think it was all his autonomics being just shut down from it.
Yeah, but wouldn't he have gotten hypertensive and bradycardic?
He didn't get hypertensive, no.
What bradycardic?
Yeah. He just started smelling.
Right.
I mean, I didn't give him any other, I mean, he got fentanyl post-intubation was the only med I gave him.
Right. For the magical fentanyl help in ICP, where there's not terrible literature about that too.
It was just more to keep him comfortable for the endotracheal tube.
Right, of course.
That was
Yeah,
all.
right. Because pain
I wasn't
first,
giving him
pain first, sedation second during
I wasn't
intubation.
giving him ICP doses like the 7 micrograms per kilogram doses.
Right.
I wasn't doing that.
Right. We all used to do that. We also did, right, but then we all stopped when the science.
Question out there, did you talk to the paramedics and compliment them on the use of the King tube?
Yeah, they did 2 attempts and they put the King tube in, and it was excellent. I wish I could give them a direct shout out because they did a great job, but you know who I'm talking about.
Right.
Those guys did a really great. It was a challenging case. The guy actually collapsed pre-hospitally and seized in front of them, and I think it was all.
Well, to be clear, the only reason we can't compliment them is because we just need their permission to say their name. Right? If we had their permission, we would say it. We just don't know. But right, I mean, that's a great job. I mean, I think it's New Mexico actually gives paralytics with King tubes. We're actually switching from King tubes to iGels.
Yeah. I tell you, it's a whole different airway, intubating post-King tube. I mean, I don't think we see enough of it or do enough of it. I mean, that.
But that was good,
I mean,
right?
it's
You
a
don't have to
red flag when
intubate.
they say that I have a difficult airway, we put it in
Right.
a King tube in. Just go into that situation knowing it's going to be fine.
Right. It's a little bit of a dramatic statement, but I don't care about the airway in 2019 that much, right? We know this. It's circulation, airway, breathing. Peter Safra was writing about this in the 60s. Circulation, airway, breathing. Circulation, airway, breathing. If somebody focus on the circulation, not the freaking airway, right? It's okay. Right, you need circulation first. So if that patient couldn't get intubated, it's totally okay. And you don't, in an emergency department, especially in a community emergency department, focus on the airway, focus on the circulation. Leave the King tube or iGel or supraglottic airway alone, and put them on a vent with the supraglottic if you can. But otherwise, just
She
keep
went nuts. It was
right.
hilarious.
Just keep bagging the
Very
patient
anxious.
a little bit, right, and just focus on trying to get some circulation done.
Yeah, she was really hesitant about me putting her on the vent. I'm like, just do it.
Right. In fact, you were already decompressing the stomach, so that's what needs to be done. Yeah, I mean, the patient wasn't hypertensive before you. The blood pressure was borderline.
Yeah, it was really borderline when we came in. I mean, it wasn't high when we first got there.
No, it was very low before any paralytics or
Right.
sedatives.
So this is what happens when you get
transfer.
somebody paralytic. The first thing that happens is they tend to get a little hypotensive, right? Because you take a respiratory state, which is a negative pressure status, and you make it into positive pressure ventilation, and the blood pressure goes down. It's okay. It's great with our CHF patients where blood pressures are really high anyway. But with the people who are septic or have one catecholamine left in their body, or who are actively bleeding and you're behind with fluids, especially blood, you just run that risk. You just got to prepare for that. That's why you have to have a push dose pressor in your hand at all times in life,
Absolutely.
right? Or you just have to anticipate it, right?
We optimized everything when you had something else.
I was going to say, I forget if EMS had given paralytics and sedatives
No, they did, yeah.
initially in the
It's part of
field,
their
Right.
arsenal.
and then were unable
Yeah.
to pass the ET
Right.
tube.
What was the induction agent? Ketamine? Yeah, ketamine, we're in love with ketamine, but we all know that even if you have one catecholamine left in your body, ketamine 2 will make you hypotensive,
Yeah.
right? So it's it's a great drug, right? Somebody was just in my office, said, why does everything in your office say ketamine? I said, 'cause it's the only drug to have. But nonetheless, there's a risk with anything. Okay, other cases? One
Just
more?
got back from South America from the time of that. That was
For a flight?
Yeah.
Yeah.
Yes, we went down. We got a 59-year-old lady with flu pneumonia, and she was in the ICU. It was pretty impressive. She had a underlying history of cardiomyopathy, and they were actually 2 serial echoes showed that she had a worsening in her cardiac output, and sent her back to New York. Do a critical care
So
flight.
she had pneumonia from the flu. So it's all right. So it's been a busy flu year, right? And the flu test. Do we normally get flu tests on people?
No,
No. So are the numbers where we're reporting the flu accurate?
absolutely not.
That you hear on the news, what percent of states have flu? Are they accurate? No, they're completely wrong.
I mean, it's
right?
extrapolation
'Cause we
based on
don't test
data.
Flu
Yeah.
on the front line, right? Because if we think you have the flu and your test is negative, you still have the flu. The test by no means is a perfect test. It's not that sensitive or specific. It, if I think you have the flu, then you probably have the flu. All right, number one myth about the flu. Number two, is Tamiflu a good drug? The drug everybody wants, right? So why is it not a good drug? Because it doesn't help that many people. First of all, it makes about 50% of people, depends on who study you believe, nauseous and throw up, right?
Or diarrhea.
Or yeah, I guess you're sicker, and you have to take it within 24 to 48 hours of symptom onset, and it helps you get better by, it depends who study you read, by half a day to 1.5 days for an illness that could be 10 to 14 days, right? So I tell people this, and then I say, now do you want the Tamiflu? And a whole bunch of people still say yes.
Yes,
Because they
always.
feel so
Especially
terrible with the flu, right? They want one drug that will help them get better by a couple of hours, even if they're, so when they come back the next day and they're throwing up, you go, is it the illness or is it the Tamiflu? I just don't know.
Yeah.
Or what you see too many people do is just give a Z-Pack and Tamiflu to everybody who comes in automatically. So now for their viral infection, they're getting like antibiotics plus the flu. So people get pneumonia from the flu? Sure. Right? And you just had one, and what, a multilobar
Yeah.
pneumonia who was hypoxic.
Lungs sounded terrible. We took her to altitude. Her SATs dropped to the high 80s.
And so my guess is it was probably viral.
Yeah.
But we have no good way of figuring out bacterial versus viral, so we give antibiotics. So
Right.
she's probably on antibiotics.
Correct.
And there's nothing more you can do that's good besides maybe some albuterol and maybe optimizing oxygenation.
That's what we did.
And what else are you going to do for these people, right?
So-
But most will get totally better, right?
Yeah.
And I guess if they get sicker and sicker and you can't oxygenate, then you can discuss putting them on ECMO, right? Which is rare, but we've all had cases where we've done it every now and then.
Yeah.
Other than that, you just keep them on the vent and they just gradually get better, right? And so your patient got sick at some remote place, I guess, and was being transferred to a bigger academic center.
Yeah. 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 It was a good trip.
What bacteria causes a pneumonia on a chest X-ray? Now, what bacteria? That's a dumb question. What bacteria is influenza associated with on the chest X-ray?
Staph aureus.
Staph aureus, right? So, what kind of lesion is on the chest X-ray?
Cannonball?
Cavitary lesion. What are the other types? What are the things that cause cavitary lesions on a chest X-ray?
Tuberculosis.
TB.
sepsis.
Abscess,
Klebsiella.
Klebsiella.
We said TB, right?
So there's no mnemonic, right? Tanks. T is tuberculosis, A is aspergillosis, N is nocardia, K is Klebsiella, and S is Staph aureus. But septic emboli can cause cavitary lesions too on chest X-rays, right? But it's a classic cavitary lesion. Like you think of it, you think of TB, right? And what else? So I guess you just patient was intubated.
No.
Yeah.
Did well. Not intubated.
Wow.
Nasal cannula on the flight and came home. It was
Wow,
fine.
I would have been worried the patient would have gotten sicker in the air.
Yeah. We had everything, but she did well. She actually turned the corner that morning when they actually started her on steroids. She said she felt much better. They started on corticosteroids and more
Well, steroids
treatments.
make everybody better for every reason. So they gave her steroids for viral pneumonia. All right, what do you think about that?
I don't think it hurt. I
I
mean,
do it in asthmatics.
Yeah.
Actually.
Sure, but asthma.
Even if they're not wheezing and they just have a pneumonia and they're
It's an
like,
old
oh,
Jerry
I just-
Hoffman thing. If you show up to an ER with a history of asthma, you probably need some steroids no matter
Right.
what.
Yep.
Right. There are two, and he always gives me, and then we'll stop here for the cases. He used to say there's two types of people with asthma. You get to somebody's house, 911, there's a patient who's been sick for a couple of days, and the patient who's really sick, that just started a couple of hours ago. Who are you more worried about? The patient who's less sick for a couple of days, or more sick just for a couple of hours?
More sick.
So less sick for a couple of days. Less sick for a couple of days has mucus plugging.
Yeah, I'm
right?
worried
And
about them
mucus
more.
Plugging you can't get rid of very easily. So anybody who says I've been sick for 3 or 4 or 5 days, be very worried about it. Anybody who says I just got sick like in the last couple of hours and they look worse, you know,
They turn
oftentimes
around very
you can
quickly.
Throw everything at them, and many of those people will get better. Not everybody, but many. But the patient who's been a little sick for a couple of days, I worry that if they get sicker on me, I may not be able to get them better without intubation because they have mucus plugging. and that they need to be bronched for. Luckily, at MG1, we have a bronchoscope. All right, so let's do the articles. Which article you want to do first? What do we do?
The microphone.
All right. So this article is about how Hurricane Harvey in 2017 affected the EMS call volume, and then talks about some teaching points about providing better care for the victim of the future natural disaster. So I don't remember about this Hurricane Harvey, but Hurricane Harvey occurred during August 17th to September 1st in 2017. And then it was one of the largest recent natural disaster in the US, since it was the first Category 4 hurricane to hit Texas since 1961. And then there was 82 fatalities from the Hurricane Harvey. So this study was done in Galveston County, which is located in the south of the Houston. And then this study describes Galveston County in the Gulf Coast was impacted by massive hurricane. And then they talk about how this information can be used to create effective strategies in the future natural disasters. So they reviewed the EMS calls of the Galveston Area Ambulance Authority, and they collected the data, including total calls for the 6 days prior to the landfall, and 6 days during its course affecting the Texas, and 6 days after the storm. And then these data periods were compared with the number of the calls during the same time period in 2015 and 2016. So what they found was that there were 882 calls to EMS during the study period. And then this was more than the number of calls for the same time period in 2016 and 2015. And then, however, what they found was there was no statistically significant increase in daily call volumes before, during, or even after the hurricane in the specified 6 days group. But there was a significant peak in calls over a 4 days period that can be attributed to the storm. And then that period was during the last 2 days of the storm and the first 2 days after the storm. And then the daily average calls volume for those 4 days was 65 plus minus 3 calls, compared to the average number of the calls for the total 18 days, which was 49 plus minus 12 calls. And then they also found that there were a large number of calls with the complaints of injury and a generalized pain, respiratory distress, chest pain, and generalized weakness. So discussion is that, so what they can learn from this study is that now that we know that the increased call volumes is likely to occur towards the end of the storm, and then the initial days following a storm, we can be well prepared by allocating the necessary resources in those time periods, so that EMS dispatcher should be aware that calls maybe go high, and the local emergency departments should be prepared by staffing more nurses, ED physicians during that time period. And then what they also say is that during they found that during that storm hitting the area, there was a drop in the calls. This could be because basically they are confined in their home or where they are, and then they may have the power outage, and then so basically people cannot reach to the EMS system while that storm is hitting the area. But as soon as the storm kind of goes away from the area, people start making some phone calls and then ask for the help. So we need to be aware of that fact, and then I think our local EMS system should be well prepared. And then now that we know that once the storm hit the area, there was an increase in the patient with the injury and respiratory distress. So the local EMS and ED should be well prepared with the extra BiPAP machine or medication to treat those conditions. And then another thing that they mentioned is about the dialysis. So dialysis patient needs to go to the hospital maybe 3 times a week or so, but they will not be able to do so while the storm is hitting the area. So they said they thought about like initiating the mobile dialysis center so that to decrease the burden of the local ED after the storms and stuff. I think it is interesting because storm can be, we can expect or forecast the storm coming. So I think this, unlike this like earthquake or tsunami, something that is we cannot predict. The storm, in case of the storm, we can be well prepared by knowing this fact.
So there's a couple of things with this article that it came by our desk, specifically to do with EMS, fire, basically first responders in general. Is if you know that something's coming, you can do a little pre-planning. Evacuate people who are going to need more help, things like that, and that's what's happened in the past. So that may have contributed to their numbers as well, that they didn't really see necessarily a high increase, but your common calls might go down, but then your more acute calls go up. One thing that you have to think about is time on task. So a regular transport that you're in and out, you can get it done in 30 minutes or an hour. Some of these calls you might be on scene longer because you have to extricate them. There might be a rescue involved where you have to get someone out of a building. Thinking about electricity, some people don't think that if you have a big storm, a national disaster, you might lose power. So what are people in your own community who's on home vents? Do they have backup power? Where can they go when something goes wrong? At least just to recharge their batteries, because they might not necessarily need the hospital services, they just need power. Some other thing is specialty patients, people on VADs, they need power. And then staffing accordingly. And then also staffing for the next 2 days, not necessarily be in-house for the actual storm or something. And we've seen recently where they've actually shut down emergency services during a major storm, and I don't know if that's good or bad. I mean, I think it's better for our responders because, listen, you've had 5 days to figure something out. We're not going to risk people's lives to, pull you out because you decided that you're going to be stubborn and not leave. That's different from someone who is, didn't have time to plan. That's something that, I wouldn't say that we shouldn't go, but if you have all this time to plan and then suddenly you want to risk, 5-10 people's lives just because you decided not to evacuate, that's something that is a bigger discussion, but it's something on the local level.
It's always a groups of dialysis patients, right? It's always a problem, and I don't think we've ever figured out a good answer. What if we took all of these dialysis patients who wouldn't be able to get to the hospital and just relocated them to some center, some special shelter which has dialysis machines, dialysis nurses in it? What if we did that for a whole geographic area?
I mean, it's definitely possible, but what we found when we travel in our disaster work is sometimes the dialysis places are the only places that actually work because of funding. If they don't dialyze people, they don't get paid. So they already have emergency generators, they have water filters, they have backup water supply, backup power.
Right.
In some of the countries that we've gone where it's a natural disaster, we were worried that all these dialysis people would need dialysis, and none of them did. I mean, in the places that we've gone to.
What day did the call volume go up?
I think it's the
days
first
after
and
the
second.
event?
First and last 2 days of the disaster, and then first 2 days after the storm went away. Yes.
So the last 48 hours after disaster, or the last 48
So
hours
basically-
after disaster ends. So you have to predict when it will end.
Mm-hmm. I mean, in terms of the storm, I think it's pretty easy to predict.
Well,
Yes. I don't.
Probably depends upon
sure.
where they
20%.
are.
yeah.
Probably depends on the patient demographics, where they're
Right.
located, what country they're in,
Sure.
I guess it's important to keep checking out your patient population,
Mhm.
right, and knowing like what will happen to your patients and what percent of your patients are dialysis patients,
Yeah.
and et cetera, et cetera.
I mean,
And
we're no,
geographic sites
yeah.
as well, I guess.
we're no stranger to this in New Jersey. You know, I was BLS during Hurricane Sandy. I know you probably were too, Jim. And you know, our call volume definitely was. It actually slowed down in the height of the storm, kind of similar
Yeah.
to what we were seeing here. But in the days leading after it, once people started losing heat and started losing power,
Right.
and a lot of it was for like very, I'm not gonna say silly things, but not emergent conditions. It was like the back pain patient who, you know, ran out of meds or they hadn't prepared, kind of similar to this. And during the storm, we had actually a lot of surgical patients who were discharged from the hospital to try to empty the hospital before the storm. And they went home and had drains to check. And they said, how am I going to check drains if I can't see anything because I have no power?
Right.
And then they needed to ride back to the
But
hospital.
what do you do? I mean, the hospital staff can't get to these people.
Right.
They're calling EMS. We bring them to the emergency department. And what do we have to offer them?
So I'll tell you, like I've worked during multiple storms, and if they need their drain check, I check their drain, and then I discharge them, and they end up sitting in the waiting room until the storm passes. So unfortunately, that's what happens. Like one of the things that in some of the disasters that we've responded to together, the Ministry of Health for that whatever place that we were going to told all the PMDs like, hey, this natural disaster is coming. We know it's coming. Write extra prescriptions for your patients so they have extra meds. Make sure they have their insulin. Make sure they have all these things so that everyone is ready. So they didn't see that problem where people are like, oh, I ran out of my meds, things like that.
So once again, it's prevention, evacuating patients from high-risk areas
Exactly.
beforehand, and having a plan for a place for them to go to.
And then based on some of this data and some anecdotal data that we were just discussing here is you don't need to staff your emergency services for the actual event itself. You should be staffing them more towards the day after, the next day, the next 2 days leading up to that. So things to think about.
But we don't evacuate dialysis patients well, do we?
Not at all.
There must be some other solution.
There's a lot of subset of the population too, the patients that require just oxygen. People have
Right.
oxygen concentrators, and,
It runs on power.
And a lot of times what ends up happening is that we end up just housing a lot of patients just waiting for oxygen.
Right.
That's a good majority of our patients too. And those patients we can't just discharge. We can dialyze patients and get them out. But there's a subset of population that they just require oxygen. We have to sit on them until we can get them power or a place that we can get them oxygen.
And most people who are on home oxygen will have maybe an D cylinder or even an E cylinder, but they don't have like the double E's or the things that. But something again, prevention and planning. You know that something's coming. You can actually make sure they have enough supplemental oxygen to help with that. So.
All right, that was good. What's the next one?
I have the next one.
Next one's another oddball.
Yeah. So this was an article. You can probably pull it up on the screen there, Navin. Thank you. Entitled Maternal Out-of-Hospital Cardiac Arrest, a retrospective observational study. So this was actually done in Paris, France, and the goal of the article basically was to describe a cohort of maternal cardiac arrest patients within their population of general out-of-hospital cardiac arrest patients. So in Paris, it's kind of nice. They use a similar system to what we do in New Jersey, a two-tiered response system.
They were both.
They were actually talking about ECMO, so they do ECMO in the field there. So if anyone's watching from Paris, that's awesome. Keep doing what you're doing. So cool. So they have a BLS unit, which is comprised of first responder, EMTs, and then an ALS unit, which is interesting. It's actually staffed by an EMS physician, an RN, and then I believe a driver or a paramedic. And they took a look over a 5-year course to see how many patients of their out-of-hospital cardiac arrest were pregnant women and their outcomes, what happened to them, and, what ALS and BLS did, essentially. So they had a total of, in this 5-year period, 19,515 out-of-hospital cardiac arrests in the city of Paris, which, I mean, if I think about that number over the course of 5 years, so we're saying 20,000 over 5 years, 4,000 a year, high, maybe?
4,000 a year. How many people
In one
live
city?
Paris?
That's a good question.
9 million.
9 million?
9 million, 4,000.
Maybe
a year.
not then.
It's not that much.
Yeah. So they took a look at that, and they noticed that out of all those cases, there were 16 of them that were pregnant women. So they broke them down into which trimester, and in terms of viability. So about half of them were prior to 20 weeks in terms of their gestational age, and then the other half of the patients were viable. And out of all of these patients, they looked at how many survived, how many of mothers and how many fetuses survived to a 30-day period, and it was only 2.
So wait, so 9 million people live in Paris. They had 16 pregnant women in cardiac arrest over 5 years.
That's correct.
And what percent were first trimester?
50. So 1, 2, 3, 4, 5. So about 1/3. So about 33% were first trimester. And out of the patients that survived, it was the only women who survived were first trimester pregnancies.
And these were women who had spontaneous cardiac arrest, like not due to MVCs or not due to...
That's a great question. So some etiologies were unknown. There were some missing data. But I think the majority of them, there was medical in 7 cases, and then traumatic in 4 cases, and the rest were unknown. So 5 unknown.
It's hard to believe. I mean, there's got to be a bunch of women who in their first trimester who die in cardiac arrest and MVCs that we just never know they're pregnant.
Could be. I would assume so.
And then if you die in MVC, I mean, how would we know you're pregnant if we pronounce you in the ER? Because we're not checking pregnancy tests in traumatic cardiac arrest patients, right?
Right.
And they don't necessarily get an autopsy, so you wouldn't know either.
Right.
So the only patient who survived with a fetus that went to term was actually P2, which was 7 weeks in gestation, and the fetus actually, this is perhaps the most interesting thing to me of this whole study, amongst some other things. So this patient in particular received 5 doses of epinephrine in the field, which we're told is contraindicated in pregnancy for your status asthmaticus patients. And they had, she was defibrillated, but I guess did not need any chest compressions at the hospital. And her fetus survived to full term, was delivered healthy with no complications at all.
And what was her status?
She was a cardiac etiology.
And she died.
No, she was fine. So her and her fetus survived. The only patient out of the study. After getting 5 doses of epi, which we know probably doesn't work, but her fetus survived a full term.
And I thought if you're like a 3rd trimester and you have a cardiac arrest, it's either due to like a PE or an amniotic fluid embolism or something along those lines, or trauma.
Right. So the 3rd trimester patients, none of them survived. This was a 1st trimester patient, the only one who had a good outcome.
So could they have all survived if they had an emergency section?
I'm glad you mentioned that. So this is the other half of the study, which is pretty interesting. So there were only 3 patients out of the 16 who received a perimortem C-section. Guess what the average time was?
Much greater than the 4 minutes that's suggested.
So out of the 3 cases, they were 55 minutes, 90 minutes, and 110 minutes.
Jeez.
It's already too late.
Which is
So-
abysmal.
But they have pre-hospital physicians.
Exactly.
Why it taking so long to take the baby out?
Well, that's a great question. So if we kind of skip ahead, if you want to skip ahead to the conclusion of this study, I don't actually agree with it. They basically conclude to say that, an EMS physician should, at the moment, they don't recommend performing out-of-hospital perimortem C-sections. So
Do it. That's the time to do it.
Why not?
I don't understand why not. There's no reason to say why not, but
It's
every
because they're not emergency physicians. They're ICU docs who work pre-hospital with no training in OBGYN.
I mean, they cite that there's no NICU person available. There's no, other.
But they only
People
then you just let
available.
everybody die.
Well, that's the thing. Half of these, like
These
half.
are not EMS docs.
Half of these patients even were pronounced in the field. So we're talking people who stayed on scene, were resuscitated to the point of pronouncement without getting perimortem C-sections with viable
Well, that's
fetus.
just silly. They're taking 3rd trimester women performing cardiac arrest and they're staying on scene, and
Yes.
they're not doing C-section.
Correct. In this study.
Yeah, that makes no sense.
And the other crazy thing about this is when you talk about response time, so I guess that could be a rate limiting factor, right? Let's say your closest EMS doc is an hour out. Well, it's already an hour at that point, but the response times that they talked about in this article were 10 minutes on average
Right.
to get an
Well-
ER doc or
Oh, really?
to the
Okay.
field.
I mean, how long should it take you to cut the baby out? I mean, 2 minutes at the most.
Correct.
That's if you're fumbling.
Right. So I think this is, I don't know, I think it's it's extremely important that, this patient population was described because this is such a rare event that, we don't see very often. And personally, whenever I go on to an emergency shift, this is the case that I'm scared of getting, that I don't want to have to handle if I can avoid it. And on the way to work, sometimes I'll use like mental rehearsing and I'll think about procedures and things that I do. I'll run everything step by step in my head, and this is one of them that I think about on my drives. And I'm wondering,
I mean, it's a cut. I mean, it's a cut from
stem to stern.
Yeah, I mean, it's a cut down to the symphysis pubis, right, over the abdomen, and you keep going until you get to the uterus, and then you take the baby out. I mean, it's obviously it's just something you don't do frequently. That's why.
Exactly.
Something that you don't want to do frequently.
Right.
But
But the problem is then you could be resuscitating mom and the baby simultaneously.
right.
If you're in a hospital, which is NICU, you can hand the baby to somebody, and then you're done with the baby.
I mean, I'm thinking, what if I'm driving around today and, an EMS physician, I'm out in a field and I go rendezvous with the paramedic unit, and I come up on scene and they just lost pulses right there in front of me. I feel like if I'm going to give mom and fetus a chance, at all after reading the study, and I'm far away from a hospital,
Right. So let me ask you
what
this:
do we
how's it
do?
any different from tonight when you go to work in the ER? At the same, somebody brings in this patient.
If it's a witness arrest and if it's
Right.
under 5 minutes,
You would just take the baby out,
cutting's the right answer.
right?
So should we be doing this as EMS physicians?
Right, I think so. I mean, you
Field.
do it today. We have the equipment. You do it today, right?
Right.
The scenario just doesn't present that much, but
I would do it without hesitation. You have the right patient, the right indication. I'll start prepping. I would actually even go as far to say I would strap myself in and just proceed to the hospital, and I'll do this en route if I have the room and the manpower to do it, because I'm going to need to have a second team
yeah, I would do it
just to take care of the baby.
A slow drive, right? So
Yeah.
a slow drive.
Yeah, lights
just like
and
the cardiac arrest should be, right?
exactly,
It's a slow drive to the hospital.
nice
while
and
you're doing
safe,
it.
and just get it done. So.
And you're slow drive to the hospital because if a kid comes out in respiratory distress and mom is obviously in distress, now you're going to have to handle the bleeding mom could be having, plus the baby, plus the mom, and you can't, and that's too challenging.
Yeah, and then after I deliver the placenta, I would close and I would give TXA and oxytocin, and
Right.
We have staplers, pre-hospitally, so
I would
that's
just
a good
staple.
indication
I
for
wouldn't
it.
do anything. I would just staple everything after you're done. I mean, you want to give TXA, sure. You want to. I wouldn't worry about closing too much. I would just pseudo close, right? And then, and I wouldn't worry about the placenta, right? At all. Who cares? And yeah.
I mean, the whole theory behind it is you're just offloading that vena cava and major vessels with a gravid uterus. You just want to empty the uterus out.
Right.
Right. So this study, actually, the data that was collected from it was before AHA and everyone switched recommendations to displace the fetus off of the vena cava. So that was one thing they mentioned in the study, is they're not sure if survival would have been better if that was in place at the time. So
I doubt it's probably only true if you still have a pulse. Once you lose your pulse, I doubt that could have helped too many people, although anything's possible.
yeah.
I just think once you go into cardiac arrest, it's probably not beneficial. Plus, the vena cava is kind of funny. I mean, sometimes you have to push, the opposite way too to get the baby out the vena cava, right? We all learn that. If one way doesn't work, turn mom the other way.
Right. Yeah, and just so everyone knows what we're talking about in general, if you can feel like the gravid uterus and move it over to the left, then theoretically that should help mom with her hypotension.
Patients left.
Patients left.
Or turn mom that way too.
Yeah. So I'll just take a towel roll or I'll take a sheet roll and just pop it right under the right hip or right rib and just kind of tilt a little bit. and just make sure whoever's doing CPR understands that it's not going to be straight up and down anymore.
Right.
The point we were making is that sometimes the vena cava is kind of funny, and you have to push the gravid uterus over the opposite way
Right.
to resolve hypotension. So just be cautious.
I wonder if you used like the auto pulse from Zoll or something like that. You could roll that on the inside since it's an actual band that's doing the compressions, offload.
That would be fine.
Right.
And as long as because you still have a sensor for the person's weight, so as long as the weight band is still detecting the person's weight, it should be able to do it. But if you tilt it too far and the weight band is no longer detecting the person's weight, it'll throw an error code and say reposition, realign patient. So that's the only downside on the auto pulse one of it.
You guys have that here?
We did.
The Lucas works at 30 degrees, I know. If you have them sitting up 30 degrees, that you can swing with the Lucas.
You can roll them on the side.
Whatever, but sideways.
Yeah, for ours it wouldn't be as an issue going up and down. It's more, if you were saying, leaning towards the side, left or right, to displace off the vena cava. But going up and down, it would still put a decent amount of weight on there, and you would have no error.
I mean, if you guys were pre-hospital, my advice would be just take an ultrasound, look at the vena cava,
Yep.
and then push the gravid uterus both ways and see which offloads more.
Yeah.
Yep.
Right.
If you have enough hands, absolutely, sure.
Or empty uterus and it goes back to the dominance.
Of course, the other thing is if mom's bleeding, I bet that the whole theory doesn't hold true about the gravid uterus, right? Because the vena cava is going to collapse if you're exsanguinating, right? So my guess is that it might not even matter which way you push the gravid uterus if you're bleeding out, right? Don't you think?
Mhm.
So, but I would still put an ultrasound over the IVC and just see in terms of volume.
But with no forward flow or no.
So if you're bleeding out from placental abruption or even previa, I mean, you're in trouble. Nothing's going to work.
Right.
Sounds like a Roboa case. Of course it's a Roboa case. You guys know this, right? Placenta previa is one of the worst things you can bleed from known to man, right? The placenta can bleed like 500 mLs per minute, right? And you have the average adult has about 5 liters of blood in their body. So they're going to bleed out before I can stand up out of my chair, right? That's how fast they go. But yeah, I mean, bleeding out.
That's his own 3 Roboa cases.
I mean, this is why in Houston they're doing there's potential for a Roboa case because they see a lot of postpartum hemorrhage near the border who are exsanguinating, which we don't really see here, or medical exsanguinations or GI bleeding.
You get a different balloon there.
Right.
Yeah, so it's kind of interesting. They sum this article up at the end with a figure. In figure 4, it's just a mnemonic they use to aid what to do. And like any cardiac arrest, it's not much different. The cornerstone of any good resuscitation is good chest compressions first. So early defibrillation, good chest compressions with BLS. And they did mention back mask ventilation, which we know we don't want to overdo it either. And they said all BLS providers should first check the term, and then as a secondary, the ALS team in this tiered system should confirm the term pregnancy and then start thinking towards etiologies and resuscitate. So like we talked about, Roboa, blood transfusion. And then they actually had one case in here. You mentioned pulmonary embolism before. EMS physicians, they had one case where they did give TPA in the field for presumed PE, which actually was confirmed later on CTA. Patient eventually expired, but Doc was right.
PE and the third trimester bleeding is in cardiac arrest to give TPA. I don't know whether it's, that's a lot of balls or just a dumb thing to do. I mean, I don't know. Maybe you're having cardiac arrest from an arrhythmia. Maybe it is something compressing on the IVC. I guess if you're a hero, if they get better. But,
Right. It's risky.
Yeah. What if they're placental abruption or something?
It's tough.
Because what are you going to do with placental abruption? They're going to hit the ER, and the only option is to get them right into an OR, which we just won't do very fast.
Right.
It takes us 2.1 hours to get our traumas into the OR, proximal control. What does it take for our placental abruptions?
And that's with everyone
Right.
in the hospital too. So. And the reason why she mentioned the 20 weeks is because less than 20 weeks viability is questionable. So
Right.
if they're less, then we really wouldn't necessarily try to do the emergency section. But above that, there's a possibility. So.
Because about 20 weeks goes right to, above 20 weeks goes right to L&D.
And if it's above, so the way we can tell, like a rough estimate, is if you can feel the fundus above the umbilicus, then that's probably around 20 weeks.
Right.
Right.
No.
But 24 weeks is, depends your study of it, but 24 weeks is about 50-50 chance of survival.
Yeah.
Right, so you really want them to be 24 weeks or greater.
That's what they use in this study as well. And
Yep.
just what Navin said, fundus above the umbilicus. Just no matter what level of care you are, it's a good thing to have in the back of your mind just how to roughly estimate this. If you're the first person on scene or you roll up on a cardiac arrest and, it's something you could tell dispatch, it's something that
Right, and I
helps.
tell BLS providers all you have to do is just take a quick look, just see if the baby's crowning, right? So you just have to know whether you're going to stay on scene or go.
Right.
I have too many people where the baby was in mom's underwear, or it was a foot-length presentation in mom's underwear, and just all you got to do is just take a quick look. You don't see anything, you can just go, nice and simple. You mentioned the cardiac arrest before, right? Continuous compressions, don't overly bag. Bagging is generally a bad thing to do. For every 5 seconds you interrupt compression, survival goes down by 17%. Do not interrupt compressions ever, or you'll be reducing the chance of a good outcome. And underventilate, not overventilate, right? So I pretty much, unless I have an end-tidal CO2, which everybody should have, I never ventilate more than 6 times a minute, ever. That was good. You'll do one more?
And that's it for the article.
That's
Is
it.
it for the articles? All right.
Yeah.
Anything else? You want to do any other interesting
Do
things?
you have your BLS case you told me about you want to do?
What day you want me to do it? When?
Yeah. Jimmy's
Okay.
BLS case.
Just no names, no hospitals, agencies.
It's the light is red for some reason.
It's okay. It's just the battery here.
Yeah, can you hear this thing?
Here we go.
Great. So we had one where it was responding for a 19-year-old unresponsive. When we got there inside the room, we were informed by family on scene that she had come home, apparently, and may have been home for around 4 hours or so because the mother was there but never checked on her. Someone walked in, saw her unresponsive, they called us. We got there. PD on scene had already given, or were in the process of giving 1 dose of Narcan. We had
So we'd
a
like to guess now before you go see more information. So was there any trauma?
no evidence of trauma. No.
So, 2019, unfortunately, overdose, heroin, fentanyl, until proven otherwise.
And that's what we're going with too.
Yeah,
So
young
PD
woman, so alcohol even, or even robotrippin. You can, the list goes on and on. Yeah.
So next clue on scene that was very strange was that there was a blue substance to the right-hand side of her. So it was about 6 inches worth of fluid just on the ground. And we're looking at that, trying to figure out what's happening. A little bit of blue around the noses as well. Nothing visible inside the mouth.
I don't know, although it makes me think of Breaking Bad when the drugs were blue.
Like dark blue, bright blue.
Like a dark blue.
Okay.
Almost to the point where you'd start to think maybe some type of a detergent or something.
So the other thing is sometimes,
Tide Pod.
yeah, some sort of detergent or some sort of chemical. The only other thing I could think of is sometimes like Pseudomonas bacteria like produces this green bluish color like in the ear infection, sometimes in the nose, in the mouth. So just a thought.
So again, the PD had given 1 dose of it, kind of her respiratory rate of around 10. So they went to try to give another dose. I'm like, let's hold off. I'm like, we want her breathing, not fighting me. So if we could not wake her up all the way, let's see what's going on first and figure out what the scenario is. So along with that, she had like a thready radial pulse. So what we did was we threw her in the recovery position and had a high flow nasal cannula on her because she was breathing adequately.
That's good.
So we can try to figure out what's going on.
Cannula for everybody.
So they didn't
Yeah.
reach for the bag.
That's good. So you didn't reach the bag of death.
No, did not reach for the bag of death.
Because
so.
her SAT was okay and she was breathing at least 4 times a minute. Right?
SAT was
So-
high 90s, so that's what we went with.
Because the BVM would have reduced blood flow to her brain, her heart. It would have caused shunting, and it would have caused opening up of her lower esophageal sphincter and increasing aspiration.
And which, with her having the vomit on scene,
Would have been worse.
ill-advised. Again, with the pupils, they're around 3 millimeters. You shine a light, they constrict slightly, but then rebound back to the 3 millimeters right away.
Yeah. So I don't know. I'll just play Monday morning quarterback. So life's good for me. I just get to play Monday morning quarterback. So for cocaine, what % of cocaine pupils dilate? Bob Hoffman did this study, right? He showed 50% of people on cocaine have dilated pupils, 50% don't. So cocaine can constrict. The whole thing about shining lights in people's eyes for like marijuana and cocaine is probably more overblown. You see it on TV all the time for like when the police do it. It's very little utility, right? It helps a little bit, especially if they're not reactive. But beyond that,
Ours is just for documentation if we are going to be giving another dose of Narcan. We just need to dilate if the pupils were constrict, because at that point we had no evidence of drugs on scene. So we're looking for some type of indicators that we would justify in our documentation for giving them naloxone. So along with that, and then we had the PD going through trying to search to see if there's any evidence of drugs. With it being other unknown substances, any evidence of a suicide note or something like that, because it could also be something like that, especially female populations, teenage area, you might have something like that as well. So there might be some type of substance that we were taking. Again, you said Tylenol is one, and some of those like liquid gels and stuff often are a blue color or some type of thing. So we're trying to figure out what the etiology is. Again, with us, it was the idea, we're not knowing how far away ALS was. Recovery position, going to get her on a Reeves, get her out to the truck, and start going towards the hospital. And then keep monitoring the airway and suction as needed. Sorry for the dispatch, everyone.
It's okay. It's your life.
158 Ridge Road, apartment number 4.
So, ALS got on scene. We got a blood pressure. It was actually rather low.
What was the blood pressure?
It was probably around like 80/40, something like that. I remember it was low. I don't remember
Was
the
she
exact
like
number.
very thin or small?
Yeah, tiny, really
Could that
teeny.
have been her baseline? I mean, we don't know,
Could
but-
very well have been. I mean, she could just be very shape and thinner. I know Jocelyn had mentioned too, wonder if it was maybe some type of huffing with the blue, but we didn't have any like smell of paint or anything like that on scene, so there's nothing like that. Someone had mentioned could it be Tide Pods, but there was no bubbling to it detergent-wise. Was it like a drain cleaner or something? There was no liquefaction in the mouth or nothing that would indicate that there was some type of like caustic base starting to dissolve away the tissues.
Who else was home?
Mother was home
And the mother just found her.
Yeah, she was home. She was like, oh, I don't know why she didn't go. I guess she might be sleeping or something. So she just didn't go and check on her, was just doing her own thing around the house. It wasn't until the son came in and then saw her on the floor that they called.
And so mom wasn't helpful in determining what was wrong.
Not what determined what was wrong. PD then eventually did find some heroin on scene. But again, when we got her out into the truck and stuff like that, medics had to end up doing an intubation because she was starting to vomit. Vomitus was about green color, not the same shade of blue. So we assisted with suctioning, ventilations the whole time that they
Maybe
were
it
doing the
was
intubation.
like bile, just maybe it was bluish green.
It was bluish green, but again, that blue substance was a much thicker, almost like a gel-like blue type substance that was nearby her. No phone or anything like that would indicate that she was like recording a Tide Pod challenge or anything like that, because it's not generally
That's a good point. Yeah.
That's not something that you generally just do for, alone and just
Kicks.
doing it for your own amusement. You generally would try to film it, so we didn't see anything like that set up or anything.
Could have been something she just ate, which was like blue, and she just like was aspirating it. That
Could very
some
well
came
have
out
been.
Her nose.
Yeah, and again, it could have come out the nose, but
Did the paramedics see it in her mouth when they intubated?
in the mouth, we just had, because again, she vomited, so we did have some blue-green color in the mouth. But when we first initially were there, the mouth was actually rather clean.
That's interesting. So did anything wake her up at all?
Nope. A couple days after, one of our friends that knows the situation said that she was still actually in the hospital and still unresponsive. So we need to still try. I know Mark was trying to get a follow-up, but that was about it.
Yeah, making a follow up. I mean, who knows? I mean, maybe it wasn't the chemical. Maybe she wasn't breathing well and suffered like a anoxic brain injury. Just from not breathing well and lying there for so long. I mean, mom said a couple of hours. Who knows where the truth is?
Yeah.
Any other thoughts? Maybe it was just again something she just ate that was just in the nose. Maybe it wasn't chemical she was taking.
Yeah.
Whenever I hear like blue or bright blue or something, I mean, I go back to Board's thoughts, ethylene glycol, antifreeze, stuff like that.
Right.
I always think about that.
It's true. I mean, I would have really would have picked it up in the hospital because maybe who knows? Maybe somebody would have checked the serum osmolality or something.
Right. And
Maybe.
then, yeah. And then the other thought was kind of what we said before, just when Jim told me that it was just isolated to the nose, then the thought kind of goes to maybe this is huffing. Could there be some sort of ventricular dysrhythmia? So I'm making sure these types of patients I throw in the monitor very early. And
Right, but that was good. So the high flow nasal cannula, how much did you say that?
15.
Yeah, that's great.
Just had it cranked up, and like I said, once I saw it around 10, I was like, let's not over Narcan it, and let's just keep it to a situation that we can control.
right.
So if she was like really hypoventilating, she could have needed to be bagged. She was barely breathing. I mean, that wasn't the case this time. She really needed to keep on that BBM. I don't know if that was done.
Would have been. We have it now.
Okay, but she PEEP on her, right? So you always need to PEEP on your BBM. We always say this. It's very simple. When you're squeezing the bag of death, look down. If there's no PEEP valve, you're always doing the wrong thing. If there is, you're always doing the right thing. It's very simple. And then, I don't know, what else would you guys have done? I mean, certainly she needed an NG tube in the hospital, right? And certainly she needed maybe, who knows, an antiemetic if she was vomiting. And who knows, she probably needed a CAT scan at some point if we couldn't figure out why she was altered. And then we might have given more naloxone, right? And what's the downside?
Yeah. I think pre-hospitally, like, the first things I think about is, unconscious person, is this some sort of poisoning? Like, CO poisoning? Is the scene safe? The rest of the family's there, so probably it's fine.
Yeah.
This blue substance, if you can safely collect it, it might help, but in reality, like, I wouldn't know what to do with it if you brought me a blue substance. I'd be like, okay, that's...
It's like people who bring in their bowel movements or
Yeah.
their spit in a napkin.
Right.
You want to see it?
Well, that happens a lot, right?
Yeah.
Thanks. I'm good.
So sometimes it's helpful, but sometimes it's not. But definitely don't endanger yourself or someone else to try and get it. And then going down the line, like you said, this is the person you want to sit up because you don't want them to aspirate on themselves. As long as they're breathing comfortably, not comfortably for you or someone else, I wouldn't give them Narcan. So definitely hold them back.
I mean, a recovery position's nice, just if they're actively vomiting, and then between vomiting, keep them sitting up. So maybe like a little bit of sitting up, a little bit of recovery.
Yep.
Yeah.
And
a jab in the rib every now and then.
That's our challenge too with the Reeves. The Reeves is going to be supine, or not supine, but you're going to be flat, and that's where the recovery position we can just, especially if they're like 90 pounds, pick up, put down, and get out of the house, get down to the hospital.
So maybe once you put it on the Reeves in the back of the truck, just put some pillows underneath the Reeves or something.
Yeah. Or remove the Reeves before.
Or remove the Reeves.
Yeah, we usually remove the Reeves just because it's easier.
Yeah, that's great.
Like I said, I usually like that 20 degrees is what I shoot for. It's just
Reeves or a scoop. Yeah. What else? Anything else you would have done in this case? I don't know. I would have given her naloxone.
I missed the blood sugar.
blood sugar was in the like 120, 130, somewhere around there.
Yeah.
Doesn't matter unless it's 500 or 0.
Yeah.
Right.
She was warm, dry, wasn't diaphoretic.
Yep.
Right. Anything else you guys would have done in the hospital? Anything else? We all probably would have done a CAT scan of her head, right? We all would have done all the usual stuff. She was already intubated. We probably would have put on some data, right?
I think what Robert said, just get a gas and CO just to check
Yep.
the box.
See if there's any respiratory or metabolic acid. Yeah.
So you were gonna go peroxyhemoglobin level with the blood gas and just see what it. Maybe you hooked her up when you got into the hospital or with the ALS just to see what the end title was, right?
Mm-hmm.
And then just scan her.
I just wait for things to come back.
Yeah.
We would have ordered urine UDS, but that wouldn't have helped us at all, right? We would have ordered it for other people. And we would have searched for other toxidromes, right?
Yep.
But it didn't sound like she had any other toxidrome, right? She was hypertensive, or she was a little tachycardic, right?
I think it was probably about. I don't remember the pulse rate off the top of my head. I think it was either a little bit like either in the 100s, 120s, but she was a little bit on the lower blood pressure end.
Right. All right. That's good. That's good.
Good job. I think that everything you guys said was right.
Yeah. Any other? We'd one more.
One more interesting case?
Yeah.
Hmm?
Anything pre-hospital? No? Okay. All right, so we will stop. Thanks for joining us. Where are we next week?
We'll be at...
Are we south?
South.
We're South Jersey next week. Thanks for joining us. Send us your questions and be careful. Thanks, guys.